Good morning, everyone. My name is Daisy. Today, I will be discussing finding possible treatment response biomarker for major depressive disorder by examining pre-treatment GABA and GLX concentrations. Over 300 million population was affected by major depressive disorder worldwide. Despite the commonness of this disease, the current treatment guidelines still recommend the trial and error paradigm, where the patients were given the most traditional selective serotonin reuptake inhibitors when they first go to the psychiatrist, and will switch to another treatment after 6 to 8 weeks if the first one doesn't work out. This approach produces very low remission rates and high patient dropout rates. The development of a prognostic biomarker was therefore required in order to assign the most effective treatment to the patient at first hand. Selective serotonin reuptake inhibitors were thought to improve major depressive disorder by not only increasing the serotonin level in the brain, but also exert some downstream effect on the outer GABA and GLX level observed in the depressed patient. Figure 1 shows the interaction between GABA and selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors work to block the serotonin reuptake channel to increase the serotonin available at the synapse. The increase in available serotonin will then lead to more frequent bindings of serotonin to the serotonergic heteroreceptors located on the GABAergic interneurons. This action will then stimulate the release of inhibitory neuron transmitter GABA. GABA will then bind to the GABA A and GABA B receptors located on the glutamatergic neurons, inhibiting the release of excitatory neuron transmitter glutamate and decreasing the excitotoxicity of the neurons. The excitotoxicity of the neurons was also related to the outer glutamate to glutamine cycle observed in the depressed patient. Glutamate failed to convert into the non-toxic glutamine form due to the decreased number of astrocytes in the brain. Selective serotonin reuptake inhibitors normalize this cycle by first blocking the serotonin reuptake channel to increase the serotonin available at the synapse. The increase in available serotonin will then lead to more frequent bindings of serotonin to the serotonin receptors located on the astrocytes, and subsequently lead to the proliferation of the astrocytes. As glutamate now successfully turn into the non-toxic glutamine form, the cytotoxicity of the neurons will decrease. Thus, as evidence above, GABA and GLX may play important roles in predicting the treatment effect of selective serotonin reuptake inhibitors. Using magnetic resonance spectroscopies, I was able to examine the predictability of GABA and GLX in the anterior cingulate cortex. The anterior cingulate cortex was chosen in this study due to its unique role in emotion and stress regulation. As part of the default mode network, the anterior cingulate cortex was deactivated during outside world interaction in healthy individuals. Hyperactivity of anterior cingulate cortex has been associated with more negative self-referential thinking and worse anhedonia symptoms in depressed patients. A study conducted by Water et al. Has found overactivation of pretreatment anterior cingulate cortex to be associated with lower pretreatment glutamine and GABA level. Since lower glutamine and glutamine has both been found to be related to major depressive disorder and patients' symptom severity is present, lower pretreatment GLX and GABA may be possible predictors for major depressive disorder treatment response. Thus, the purpose of this study is first to investigate the role lower pretreatment GABA and GLX play in treatment response in order to identify the potential biomarker, and second, to examine the clinical usefulness of the identified biomarker. All participants were recruited, interviewed, and scanned by the CUBIT lab at Stony Brook University. It is important to note that all participants will wash off medications at least 2 weeks before the experiment began. The placebo and selective serotonin reuptake inhibitors was then assigned to the patients using a double-blind protocol. A placebo control group is necessary in this study in order to isolate the effect of selective serotonin reuptake inhibitors. All data were received and analyzed by me in the Excel sheet format. Linear mixed effect model was first computed in the FTSS to assess the placebo effect. No significant result was found, suggesting that placebo and selective serotonin reuptake inhibitors may elicit the same temporary improvements in the depressed patients. Therefore, the placebo and the treatment groups were combined as one uniform group in the following analysis. Independent t-test was then performed in SPSS to confirm that pretreatment GABA and GLX level are lower in remitters compared to non-remitters. Consistent with previous literature, significantly lower pretreatment GABA level was found in remitters when comparing to non-remitters. Partial correlation was then performed using the statistics software to examine the correlation between lower pretreatment GABA and GLX levels and the degree of patient symptom improvement. Lower pretreatment GABA was found to be inversely correlated with the treatment response magnitude of the patient. These two results were consistent with our hypothesis and suggest that patients with lower pretreatment GABA respond better to the selective serotonin reuptake inhibitor treatments. Therefore, GABA may be a possible biomarker for predicting major depressive disorder treatment response. However, no significant results were found to denote GLX as a possible biomarker for major depressive disorder treatment response. GLX is as mentioned above, GLX is the combination of glutamate and glutamine. Glutamine, as the precursor of glutamate, has been consistently observed to be lower in the depressed patients, but glutamate level has been more controversial in the previous study, where both higher, lower, and unchanged level has been found. Thus, it takes caution for me to hypothesize GLX as the possible biomarker for major depressive disorder treatment response. More accurate results will be generated by separately examining glutamate and glutamine levels using a magnetic resonance spectroscopy with a higher resolution. To be clinically useful, a biomarker must be able to classify patients into remitters and non-remitters with a reasonable accuracy. Since GABA was the identified biomarker in this study, I performed a LIF1L analysis solely on pretreatment GABA level. Overall, pretreatment GABA was able to classify patients with an accuracy of 71.6%. This moderate accuracy suggests that with further investigation, GABA may be fully developed into a biomarker that will assist in personalized selection for major depressive disorder. To conclude, pretreatment GABA was identified as a potential biomarker in the current study with the ability to classify patients into remitters and non-remitters with an accuracy of 71.6%. And no significant results were found regarding to the predictability of pretreatment GLX. In the future, it is very important to further investigate the identified biomarker GABA in a large, fully held out sample and to separately examining glutamate and glutamine levels as possible biomarkers for major depressive disorder treatment response. This is the first study to show that lower pretreatment GABA predicts better selective serotonin reuptake inhibitor response in a setting with large sample size and a placebo control group. It is also the first study to take a step further to examining the clinical usefulness of the identified biomarker. If the current study is validated, lower pretreatment GABA will greatly reduce the time and money wasted on switching treatments, give patients hope in the medication they receive, and also contribute to the development of new treatment options that are more effective. Here are my references. Thank you for your time and listening.